So today, I don't know if y'all know this, but in the Book of Style, it's in section 4. There are several chapters. They're called specialty chapters, and they have a lot of different information in there. So sometimes if you have a question on a report, check out one of these specialty chapters and see if there's any information on whatever you're wondering about. There's some good information. A lot of it has to do with types of tests with different specialties, that kind of thing, different terminology. And so some of that may help you in some of your reports. So today I wanted to go over two of my favorite specialties, the cardiology and pulmonology. And I wanted to go over the specialty chapters in there and just some of the information you can find. I won't cover everything that's in there, but most of it I will. I tried to pick out mostly the stuff that you might see in reports, more of the common stuff. And so there is some other information there so check them out when you get a chance, and hopefully they can help you in some of your reports. So today we're going over the cardiology and pulmonology specialty chapters in the Book of Style. Chapter 14 is the cardiology chapter. And like I said, it doesn't cover everything to do with cardiology, but it covers some of the more common stuff. So the chapter starts off with the heart sounds. And I've actually had several questions on this recently, so I was glad to cover this part of it. And hopefully that'll help explain a little bit more about what they're talking about when they talk about the heart sounds. There are 4 heart sounds, and then there's 4 components. And they assess these by doing auscultation of the heart. So you want to abbreviate the heart sounds and the components. If they're used as a general reference or at the beginning of the sentence, then of course you would write them out because you don't want to start a sentence with a number. So a couple of the example sentences seen here are third heart sounds are usually indicative of congestive heart failure. And then if it's and then the S3 is often indicative of congestive heart failure. And the reason they use S3 instead of the third heart sound is because they're being specific there, not kind of a general reference. So here's the heart sounds. I'm sure most of you, if not all of you, have heard these before in reports when they say the S1, S2, especially when they're doing the physical exam. They'll say heart S1, S2 normal, something like that. And that's what they're talking about, these heart sounds. So the first heart sound is S1, and it's produced by vibrations generated by closure of the mitral and tricuspid valves. So I put a little picture of a heart here, and you'll see this on the next couple of slides too, just so you could see where the different valves were. So here you see the mitral valve, and here you see the tricuspid valve. When these valves close, that's when you hear the first heart sound. And the sound corresponds to the end of diastole, which is the relaxation of the heart, and the beginning of the ventricular systole, which is when the heart contracts. And it's usually a high-pitched sound. It's heard over the diaphragm. And you can Google heart sounds, first heart sound, however you want to term it, and there will be a lot of websites. Go to YouTube, different places where you can actually hear the heart sounds if you want to do that. So YouTube has a lot of it on there. There's a lot of interesting stuff on YouTube if you've never looked on it or don't look on it very often. The second heart sound is the S2, and it's produced by closure of the aortic and pulmonary valves at the end of systole. So this valve and this valve, the aortic and pulmonary valve at the end of systole, it's when they close. Sometimes you'll hear the term a split S2, and that just means the aortic valve closes slightly before the pulmonary valve. And more prominent on inspiration is when you're more likely to hear this sound. So S1 and S2 are probably the two you're going to hear the most in medical reports. Occasionally you'll hear the S3 and S4. S3 is your third heart sound, and it's heard during the rapid entry of blood from the atrium to the ventricle. So when they go from the blood goes from the upper chambers to the lower chambers. And then the fourth heart sound is S4, and this is a late diastolic sound that corresponds to late ventricular filling through the active atrial contraction. So when the atria contracts, that's usually when you hear this sound. And anytime y'all have any questions, you can just post them in the chat box, or if you have a mic and you want to talk, let me know and I'll unmute you, and then you can just ask your question. But I'll keep up with what's going on in the chat box, so just anytime you have a question, go ahead and post it. So these are the different heart sounds. Again, you're going to hear them often. You might hear S1, S2 normal. It's not S1 hyphen S2 or S1 slash S2. It's S1 comma S2, because they're two completely separate sounds. They're not in any way together. So whenever you hear that, just remember to use the comma between them, unless he says S1 and S2. Now, murmurs are something else you'll hear a lot of during the physical exam, especially when they're talking about the heart. It's there are no murmurs, or there's, a systolic murmur. That kind of is terminology you'll be hearing. So there's basically two types of murmurs. They're innocent murmurs and abnormal murmurs. Now, innocent murmur, it's just the blood just flows a little bit more rapidly throughout the heart than it normally would. But an abnormal heart murmur is usually a congenital defect, or someone had an infection that damages the heart and causes the murmur. Usually this happens in older children and adults. So murmurs are graded from soft to loud, and they are written in Arabic numerals. So the regular numeral 1, 2, 3, 4. So murmurs are graded on a scale. They have the systolic murmurs and your diastolic murmurs. The systolic murmurs occurs when the muscle contracts, and the diastolic murmurs occur when the muscle relaxes. So systolic murmurs are graded on a scale of 1 to 6, and the diastolic murmurs are graded on a scale of 1 to 4. You want to be sure to use the virgule between the murmurs. Tina, if he said and, I would use the word and not the and ampersand sign. You may have some accounts that you're typing on where they, say it's okay to use the ampersand sign, but for us, I would use the word and. So with the murmurs, again, you want to use the virgule between them, or the slash. And if he says, they dictate, so the patient has a grade 2 out of 6, then it's 2/6. If he says they have a grade 2 to 3 out of 6, then you actually want to write it out. 2, let me put that in the chat box since I didn't put it on my slide. Like that, instead of using the 2-3/6, because that can be misread as a fraction. So usually it'll be like 1 out of 4, 2 out of 4, 3 out of 4, 1 out of 6, that kind of thing. Always remember to use the virgule or the slash between them. Some different laboratories that you may encounter in reports that have to do with the heart is the CK, which is the creatine kinase, and the CKMB, which stands for creatine kinase myocardial band. And here you see it has CK-MB, all capital letters. And it's usually used as a follow-up. If they've done a CK and they've noticed it's elevated, they'll do the CKMB to follow up on that. And it's used to determine is there an increase in the CK due to heart damage or skeletal muscle damage? And that's what they're trying to determine. Why is that? Why is the CK elevated? So the CKMB gives them a more detailed reason of what's going on in the body. HDL and LDL have to do with cholesterol. HDL is your high density lipoprotein, which is your good cholesterol. So we all need some of this. And it actually helps to remove the LDL cholesterol or the bad cholesterol out of your body. Acts as a maintenance crew for the inner walls of the blood vessels to help keep them from getting deposits and becoming blocked. So your LDL is your low density lipoprotein, which is your bad cholesterol. And what this one does is deposits plaques on the wall of the arteries and can cause a blockage of the arteries. So you need the good cholesterol to take out the LDL or bad cholesterol and come along and take those plaques out. Hi, Lana. Yeah, if they're talking about murmurs, and sometimes they might say something like a 2 to 3 out of 6 murmur, and in that case, you want to type it out like that and not put 2-3/6, because that could look like a fraction and be misread. So certain things like that, you want to be sure to write it out completely. Now, if they just dictate 3 out of 6, then it's just 3/6. You're welcome. So the EKG, again, probably one you're going to hear a lot. It's an abbreviation for electrocardiogram, electrocardiography, electrocardiographic. Sometimes doctors use the abbreviation ECG. Both of them are acceptable, and unless your account specific specify, you do not want to change it. So if the doctor dictates ECG, that's what you type. If he dictates EKG, that's what you type. You don't want to change it to EKG or ECG, either one. You want to keep it. It could be a heading, and again, it would depend on your account specifics. For most account specifics, you would expand that in a heading as electrocardiography. For CanScribe account specifics, I believe it's okay to use the heading of EKG if that's what they type. Usually, these are done under a heading of either maybe laboratory or diagnostic, where they might be talking about, CT scans, MRIs, and, they did several different types of tests. So usually that's going to be under that main heading, where they'll do a diagnostic heading and then just give you everything they did under that for the different types of tests they run. No, if they dictate the term out, I would type the term out. I wouldn't abbreviate it. Especially with the verbatim account, you want to just type whatever they dictate. So if they dictate electrocardiogram, that's exactly what I would type. You're welcome. So, and if you've ever had an EKG, they're kind of interesting. They use leads that they put over your body, and they're the electronic connections that record what's going on in the heart and throughout the body. They use this by an electrocardiograph. So they have what they call the standard bipolar leads. You might also hear this term called limb leads, LIMB. And the reason they do that is because they actually put them on your limbs or your arms and your legs. That's why they call them limb leads. You want to be sure to use the Roman numerals. So lead 1, lead 2, lead 3, Roman numerals. And for the bipolar leads, that's the only 3 leads there are, 1, 2, and 3. There's not a 4 and a 5, 6, or whatever. It's just 1, 2, and 3. So lead 1 is the negative, and you can see on the diagram here, they have a lead around the left arm, a lead around the right arm, and then a lead around the left leg. So the negative electrode for lead 1 is on the right arm, and the positive electrode is on the left arm. And this little triangle in the center here, I totally don't understand all that information, so please don't ask me what it means, because I honestly don't know. And then lead 2 is a negative electrode on the right arm and the positive electrode on the left leg. And then lead 3 is the negative electrode on the left arm and the positive electrode on the left leg. So this is basically how it goes. And so that's what they're kind of looking at, how the current between those 2 different leads are running. So the augmented limb leads basically just use leads 1, 2, and 3, and then they have that mathematical formula, which was that triangle thing, and it creates the information for the augmented limb leads. So the augmented limb leads are abbreviated as lowercase a and then uppercase VR, VL, and VF. And the AVR, it has to do with the electrode located on the right shoulder. The AVL is the electrode located at the left shoulder, and the AVF is the electrode located at the left foot. Be sure to remember to use the lowercase a and then uppercase for V and R, L, and F. And then you have your chest leads, are also known as precordial leads. And this has to do with looking at the electrical activity of the heart in the horizontal plane. And as you can see, they're called chest leads, and they're put on your chest, and there's 6 of them. So V1 is positioned in the 4th intercostal space, just to the right of the sternum. That term intercostal means between the ribs, and as you can see here, it's located between, if you count down the intercostal spaces, it's 1, 2, 3, and 4. So it's located right there between the ribs. And then V2 is in the 4th intercostal space to the left of the sternum, so just on the other side of the sternum. V3 would be halfway between V2 and V4. And then V4 is in the 5th intercostal space in the midclavicular line. And that means that if you take the clavicle, go about halfway, and then go down the clavicle, that's the midclavicular line. V5 is positioned in the anterior axillary line at the same level of V4. And then V6 is positioned at the mid-axillary line at the same level of V4 and V5. So they're all at the same level. Axillary has to do with your arm. Now, if you have what they call sequential leads, you want to repeat the V. You do not want to use a hyphen. So if he dictates leads V1 through 5, you want to transcribe it as leads V1, the word through, and then V5. Not V1 through 5, V1 hyphen V5, or V1 hyphen 5. Lisa Quest. I'm not sure what you mean by that. Oh, question. Oh, okay, got it. He might not. It kind of depends on what he needs to say in the report. So he might say V1 through 5 and then dictate something and then say something for V6. Now the tracings, and this gets a little not really complicated, but confusing sometimes when they're talking about the tracings. And these are where doctors, when they're talking in the report and they talk about the P wave, the T wave, the R wave, that's what he's talking about is the EKG tracing. You want to remember not to put a hyphen after the letter unless it's an adjective. So if he just says T waves are normal, the T wave had this, hi Ellen, that's fine. Then you don't want to use the hyphen. But if they say like T wave abnormality, then you would use a hyphen because in that case it's being termed as like a compound modifier. It's modifying, T wave is modifying the term abnormality. So in that case, you do want to use the hyphen between the T or the letter and the word wave. But otherwise, you don't. Always capitalized, and then wave is always lowercase. And this is, I think, kind of interesting. I've, 25, 30 years of doing this, and doctors always dictate the term STT wave. It's very common. And in reality, there isn't an STT wave or an ST wave. So you want to be careful about how you transcribe that. So if they dictate STT wave abnormality, which you'll probably hear, you want to transcribe it as ST and T hyphen wave abnormality or as ST hyphen T hyphen wave abnormality. Now, if they dictate just ST wave, we've kind of come to recognize that term, even though there's no such thing as an ST wave. We've kind of come to recognize it and just type ST wave. Again, if you work for whoever you work for, the account you type for may have a different way they want it written. But with CanScribe, I've seen it typed as ST. So, but just be aware that there really is no such thing as an ST wave or an STT wave, even though you'll hear it all the time in reports, especially if you do a lot of cardiology. Now, echocardiography is different than the electrocardiogram. One of the terms you'll hear is the 2D echocardiography or two-dimensional echocardiography. Usually when it's first mentioned in a report, you want to expand it to two-dimensional echocardiogram or echocardiography, whichever word they use. And definitely if it's being used in operative titles, you want to expand it. Otherwise, you can just type it as 2DE, which is two-dimensional echocardiography. TEE is transesophageal echocardiography. And then IVUS stands for intravascular ultrasonography. I have heard doctors on occasion pronounce that as IVUS, which is one of those weird things of how they pronounce abbreviations as words. So just kind of, if you hear that, just be aware that they're talking about the IVUS or intravascular ultrasonography. If the dimension is abbreviated like the 2D, it's not necessary to expand it. You can just transcribe it as 2D echocardiogram. So if they dictate as 2D echo, just use the abbreviation 2D. And sometimes when you're typing, you'll hear the different classification systems that they'll use for different diagnosis that they're making. For angina, they have two classification systems that they may use. One is the Braunwald system, and that's used to classify unstable angina, which is a sudden chest pain. It usually occurs at rest, and it's usually caused by reduced blood flow to the heart. So you want to be sure to use Roman numerals. It's class 1 through 3. And they may have even a subclassification. So if they do, you want to use capital letters along with the Roman numerals. Like class 3B, it's class 3, Roman numeral 3, and then the capital letter B is the subclassification. The one that's used to classify exertional angina is the Canadian Cardiovascular Society, or CCS system. This type of angina is called exertional angina. So it occurs with exertion, and then as the person takes a rest and kind of slows down, the angina will go away. Again, you want to use Roman numerals. It's class 1 through class 4. So it would be CCS class 2 or CCS class 4. Doctors won't always say the actual name of the system that they're using. They may just say he had class 2 angina, or he had class 4 angina. They may not even say if it's exertional or unstable. And if they do say it that way, you don't have to, don't add in what type of system they're using or the type of angina, because they may at some point in the reports, like at the beginning of the report, say the patient has exertional angina, but you don't want to make any kind of assumption that that's what they're talking about with these classes. So if he doesn't specifically dictate the system they're using, what type of angina, don't add it in. The two classification systems for myocardial infarction is the Forrester and the Killip. Forrester is used to describe the cardiac function after the MI, and they also use Roman numerals, classes 1 through 4. And then the Killip classification is describing the cardiac status, and they use the Roman numerals, again, class 1 through 4. And the cardiac function is how well the heart is functioning, and the status is basically what kind of condition is the heart in. And then they have the New York Heart Association, or NYHA, classification for heart failure. You want to, again, use the Roman numerals, classes 1 through 4. Class 1 means they're asymptomatic. Class 2 means they're comfortable at rest, but symptomatic with normal activity. Class 3 is comfortable at rest, symptomatic with less than normal activity. And class 4 is severe cardiac failure, and then they're symptomatic at rest. So example sentence would be, the patient has been diagnosed with cardiac failure class 3. They may say the patient has been diagnosed with cardiac failure NYHA class 3. And one of the things when I was reading this that kind of I kept questioning was, what do they mean by normal activity? I did looked at a lot of different websites, just trying to figure out what they meant by normal activity, and the best I could come up with was what's normal for you. And, someone might be a jogger and they jog, 3 blocks every morning or 5 miles every day. Someone else, normal activity might mean, walking from the couch to the refrigerator. But that's the best explanation I can come up with what they're talking about normal activity through just looking at several different websites for this looking at this New York Heart Association classification. If anybody comes up with a better explanation, I'd be happy to hear it. But like I said, I looked at probably like 6 or 7 different websites, and they really didn't define what normal activity meant for them. Jennifer, maybe um, it could be activities of daily living. That's a good question. Maybe that is what they're talking about. I think I'm going to do a little more research into it to see if I can get kind of a better definition of it. Okay, Judy, you looked too. Okay. Yeah, they really don't define what normal activity is, so that's the best I could come up with. Atrial fibrillation, it's just an irregular rapid heartbeat. Your atria they beat irregularly. There's 3 types of atrial fibrillation. One is paroxysmal. It's recurrent, intermittent atrial fibrillation, and it really terminates without any kind of specific therapy. So it's self-limiting. It could last for a few minutes or a few hours, but then it just stops. Persistent atrial fibrillation, it's recurrent and it is sustained, and it's usually terminated by some kind of therapeutic intervention, either pharmacy, medicines, or some kind of electrical technique. And then permanent atrial fibrillation, it's just continuous. You can't convert it to normal sinus rhythm by any kind of means. Usually, if someone has this, they will be on medication, but even going in back into the doctor, doing any kind of electrical techniques, using any kind of medications, it's not going to stop the atrial fibrillation. It's going to continue on. Yes, Ruth, ADL is activities of daily living. Absolutely right. And again, if you type a lot of cardiology, Lisa, with atrial fibrillation, yeah, yeah, blood thinners, they definitely need to have them on blood thinners. Do you know what kind she has? Is it just coming every so often and stops on its own, or does she have one or the other? Last 24 hours. Okay. Yeah, and the reason they give them blood thinners is because they don't want the blood clots. So they're trying to avoid getting blood clots, because if you have uh, blood clots, say, in your heart, and the heart beats and it pushes that blood clot or somewhere else, or even a blood clot somewhere else, and it goes into your heart, well, we all know what that means. So that's the reason they give blood thinners, is to keep the blood from clotting inside the body, which, like you said, yeah, very tricky. See, Tina said technology is wonderful. It really is. My husband needs open heart surgery, which is very tricky and high risk. So his cardiologist has made an actual 3D of his heart, and we had it in our hands. So this way the team can see exactly what they need to do beforehand. Not many people can say they have had their heart in their hands. Oh, that's very interesting. And yeah, not many people can say that, but that's really interesting. I didn't even know they could do that. So if you type a lot of cardiology reports, you probably will hear this term, TIMI. That's how doctors pronounce it, is TIMI, T-I-M-I. And it just means thrombolysis and myocardial infarction. And thrombolysis is a treatment to dissolve clots in blood vessels. So it's a grading system to determine the likelihood of an ischemic events with patients with unstable angina. You want to use the lowercase word grade and Arabic numerals. So the patient had TIMI 3 or TIMI grade 3 flow at 90 minutes following thrombolytic therapy. Sometimes they may say the patient had TIMI 3 flow and leave out the word grade. Again, if they don't dictate it, you don't want to type it. So just kind of pay attention to what they're saying. And I know sometimes it's when you're thinking, oh, it's a grade 3, you might automatically add that word in even when it's not dictated because you know it should be grade. So just be very careful with that. So any questions on the cardiology or comments or anything like that? And again, if you have any, when you're doing these reports, look at the specialty and then just go to the specialty chapter. And again, you may not find exactly what you're looking for, but you may, and it could be a big help. So chapter 23 is your pulmonary and respiratory chapter. And yes, Tina, this will be on the forum. It's being recorded. So they'll get it up on the forum, and there'll be a handout with it also when they put it up on the forum. Yeah, so all the webinars are recorded, and they're always put in the forum. I'm not sure exactly how long it takes them to get them up there, but they do get them up, put them up, and usually there's a handout with the webinar. And in this pulmonary chapter, there's a whole list of abbreviations. I didn't put all of them on here. I put just really the most common ones that you're probably going to hear when you're typing. There's some that are on there that honestly I've never heard in 25 years of doing this. You may hear them occasionally, but you may never hear them. So kind of go to that chapter and look at some of the different abbreviations. CO2, carbon dioxide. O2 is oxygen. N2 is nitrogen. PCO2, and most places do type it with the lowercase p. The book of style has both the lowercase p and the uppercase p, but most places type it with the lowercase. And that means partial pressure of carbon dioxide. And then PO2 is partial pressure of oxygen. Again, lowercase p is more common, but you may also have an account that wants you to use the uppercase p. PaCO2, and be sure to look at how this is written with a capital P, a lowercase a, and then your CO2. And this one is the partial pressure of arterial carbon dioxide. So it measures the pressure of carbon dioxide that's dissolved in the blood and how well it's able to move out of the body. And then your PaO2, again a lowercase a, is partial pressure of arterial oxygen, which just measures the pressure of oxygen dissolved in the blood and how well the oxygen is able to move from the airspace of the lungs into the blood. The VQ is V/Q, both capital letters. Its abbreviation stands for ventilation perfusion ratio. And it's a measurement that's used to assess the efficiency and adequacy of the air that reaches the alveoli, which is your ventilation, and the blood that reaches the alveoli, which is your perfusion. Right, Tina, these are the letter O and not the number 0. So definitely be sure to watch that. Sometimes doctors will when they're talking about like respirations per minute or breaths per minute, they may actually abbreviate that. They may say he had 10 BPM per minute or, 21 RPM. And you want to be sure that you spell those out and not abbreviate them. They're not considered common abbreviations. So even in the case if they do give you the abbreviations, be sure to spell those out. So it's 10 breaths per minute, not 10 BPM. And it's 21 respirations per minute, not 21 RPM. RPM is also an abbreviation for, I forgot what the R stands for, and I knew it this morning when I was looking at this. Is it rotations, I think, per minute or something like that? So that could be confused if someone's just reading and say, 21 RPM. Revolutions. Thank you, Nathalie. Revolutions. So be sure that you spell those two out even if they're abbreviated. Pulmonary function testing is one of the most common tests you're going to probably hear when you're doing any kind of respiratory reports. They might be abbreviated as PFT. So that's the abbreviation for pulmonary function test, all caps. And it's just a diagnostic test that measures how well the lungs take in and release air and how well they move the gases from the atmosphere into the body. So there's, again, several of them. Some of the most common ones are the DLCO, which is diffusion capacity to carbon monoxide. And it's how much oxygen travels from the alveoli of the lungs to the bloodstream. ERV is your expiratory reserve volume, and it's the amount of additional air that can be expelled from the lungs after a normal expiration. So you breathe in some air, you do a normal expiration, and then you try to push some more air out. FVC is your forced vital capacity, which is the total volume of air expired after full inspiration, which means you just take in some air, take a breath in, and then expel it out, and that's what your total volume is. FEV1 is forced expiratory volume, and it's the volume of air that is expired in the first second after your maximal expiratory effort. FEF is your forced expiratory flow, and then FEF 2575. And again, doctors may not always dictate the percent sign, but you want to be sure to add it. And this is the only time that you will ever see the percent sign and a hyphen. Usually if you have a percent sign, if it was like 25 to 75%, it would be 25% the word to and then 75%. But with this test, it's FEF 25-75 and then percent sign. And this is your forced expiratory flow during the middle of FVC. FRC is your functional residual capacity, which is the volume of gas remaining in the lungs at the end of expiration. No space between the F and the 25. You put them right there together. And then your MVV is your maximum voluntary ventilation, and it's the greatest amount of air you can breathe in and out during a minute. Again, be careful with this one because that V might sound like a B in some cases. So if they're usually talking about, the pulmonary function test, it's the MVV and not MBB or MBV or MVB. Okay, so just think about what is he talking about, and then you can again just Google it, and you'll find this abbreviation. RV is your residual volume, and that's the amount of air left in the lungs after a forced exhalation. PEF is peak expiratory flow, how much air can be exhaled when you're trying your hardest to exhale air. SVC is slow vital capacity, which is the amount of air that can be slowly exhaled after a deep inhalation. And then TLC is your total lung capacity, which is the amount of air that's in your lungs after deep inhalation. And usually this test, this PFT, the pulmonary function test, is done with the spirometer, is the instrument they use, which is basically it looks like a big tube, and you blow into it, and doing that has a measurement guide on it, and it kind of goes up into where, like, if you're trying to exhale air, all the air in your lungs, you would blow into it as you exhale, and it would measure that amount of air. Malon Patty Samsoon. Generally, you're only going to hear this doctor say the Malon Patty system or the Malon Patty classification. And it's used by anesthesiologists and also like emergency medical personnel, so EMTs, those people out in the field, to assess the airway for intubation if they need to intubate someone. Again, you want to use lower class. The word the word class is lowercase, and then it's Roman numerals. So class 1, class 2, class 3, and class 4. Doctors may dictate it as the patient is class 3 Malon Patty. Your Epworth sleepiness scale, it's actually a questionnaire, and I have a sample of that I'll show you here in just a minute. And it's used to measure the daytime sleepiness and to help to assess sleep disorders like sleep apnea or Patricia asked, seems that all class is Roman numerals. Am I right? Are there any types that are not? Patricia, generally class is going to be Roman numerals and grade's going to be Arabic. That's a general rule, but not always. There are some exceptions. I can't think of anything right off the top of my head, but there are some exceptions that you might see where grade would be Roman numerals and class would be Arabic numbers. So it's good to check that until you're real familiar with, especially if it's a specialty, to make sure that it's going to be Roman numerals and not just assume. But general rule is yes. So in this Epworth sleepiness scale, the patient is given 8 answers. It's a test that patient takes themselves and scores themselves. And they're given 8 answers, and they use a scale of 0 to 3 to answer the questions. Then the scores are totaled, and that they arrive at their Epworth score. If it's less than 8, it's normal sleep function. If it's 8 to 10, it's mild sleepiness. 11 to 16 is moderate sleepiness. 16 to 20 is severe sleepiness, and I believe that should be 21 to 24 is excessive sleepiness. And once they get this scale, the doctor can then, if they need to run more tests to, help with whatever they're assessing them for, whatever sleep disorder they're assessing them for. So I'm going to show y'all this Epworth sleepiness scale that I found on online. So as you can see, it's a scale that the patient takes themselves, and it basically tells the doctor how sleepy they are. So 0 is no chance of dozing. 1 is a slight chance of dozing. 2 is a moderate chance of dozing, and 3 is a high chance of dozing. And these are the situations, oops, that they are grading. So if they're sitting and reading, then they just, what's their chance of dozing if they're sitting and reading? Their chance of dozing if they're watching TV. If they're sitting and active in a public place like a theater or a meeting. As a passenger in a car for an hour without a break. When they're lying down to rest in the afternoon when they're able. If they're just sitting and talking to someone. If they're sitting quietly after lunch without alcohol and in a car while stopped for a few minutes in traffic. So they grade those 3 with the chance of dozing. They add it up and then they analyze it. This one, as you can see, has a little bit different interpretation. 0 to 7, and then they do 8 to 9, average daytime sleepiness. 10 to 15 is excessive, and 16 to 24 is excessively sleepy. So I think some places might do things a little bit differently. It's kind of like with labs that have different what they call reference samples, and that's pretty much what that is about. So your doctor may give you this questionnaire, and he may have a different way of interpreting it. Tina says, I'm a 24. I know, I was reading those questions, and I thought, sometimes I can read for hours and not get sleepy. Other times I can read for 5 minutes and fall asleep. So it just kind of depends, really. On the same way with meetings and going to a movie, just different things. And Lisa asked, is that related to lung O2 and CO2 exchange? Lisa, the sleepiness scale, I was asking you if that the question you asked about the O2 and CO2 exchange is if you're referring to the sleepiness scale being related to that. Um, it could be why are you sleepy? What's going on that's making you sleepy? Someone else had mentioned that it's a questionnaire used for depression. So is that what's making you sleepy? Is it something to do with the circulation of your blood or the air? Or so that's what they're looking at, is how sleepy are you during a normal day? And then they try to figure out what kind of sleep disorder do you have. So, and that is actually it. That is my last slide. Lisa asked, when you sleep, your O2, CO2 exchange rates change. So I was wondering if you had respiratory issues, if it would affect sleep patterns. It could, yeah. I'm not, I don't know if it's unfortunate or fortunately, I don't know, but I'm not an expert in that. But yeah, I would think it could affect your sleep patterns. Um, you could have sleep apnea and different types of sleep disorders if your exchange rates weren't right. You're welcome, Crystal. Jennifer says, my mother has COPD, is on oxygen, and she sleeps terrible and always feels tired. Oh, I can imagine, because you really can't get a good sleep, a good deep sleep. Lisa, it was a yes. I'm sorry. I don't know why this keeps cutting out on me. Yeah, I would think that if your exchange rates were off, that it would cause problems with your sleep. Bye, Judy. You have a good day. Anybody else have any questions? You're welcome, Lisa. And y'all be sure to look at those specialty chapters and have a great week.